Yes. So Alice Lamb is a neurologist at Massachusetts General Hospital. Dr. Lamb has been practicing medicine for over 14 years. Her top areas of expertise are epilepsy, Alzheimer's disease, and memory loss. She has a pet turtle and she enjoys music, travel, gardening, and her favorite animals are the whale shark and sun bear. Welcome and thank you, Dr. Lamb. Ladies and gentlemen, please join me in welcoming her.
Thank you, Norma and Shanda, for that introduction. It's a real pleasure to be here with you guys tonight. So my goal is to talk about epilepsy and memory. It's a big topic, so we're not going to be able to cover everything, but we'll leave room for questions at the end. So if you have questions, write them down, and hopefully we can get to things that I maybe didn't get a chance to talk about or that maybe weren't clear from the talk. All right. So here's an outline of what I'll be talking about tonight. So we'll start by talking about cognitive problems in people with epilepsy. And I have the asterisks here basically to say that I'm mainly going to be focusing on adults with epilepsy in this talk. I'm an adult epileptologist, so less so on the pediatric epilepsy side of things. But we'll talk about different types of cognitive problems that people with epilepsy might have, the causes, how we go about evaluating these issues, and different kinds of treatments that are available for cognitive problems. And then we'll move on to thinking about epilepsy and brain aging and dementia, and how we think about epilepsy as people get older and grow older, and the effects that epilepsy can have on the brain long term. And then at the end, we'll give you sort of ways to think about optimizing your brain health if you have epilepsy, and even if you don't have epilepsy, the things that we think about that can really help improve how our brains age over time. All right, so let's start with this first section here. So I know the talk is called Epilepsy and Memory, but I'd actually like to rename it Epilepsy and Cognition, because the idea is, a lot of my patients will come to me and say, I have memory problems. And often, what they really mean is something broader than just memory problems. They really mean cognitive problems. And the feeling is that, maybe there's something about my thinking that's not as good as it used to be. All right. So there's different kinds of thinking that the brain can do. Memory and learning is one of those things, so the ability to record information, facts, things that happened to you, and store them in your brain, and then to be able to retrieve them for later use. But the brain does more than just remember things, right? So it has to pay attention. So it has to stay focused, even if there are multiple distractions or multiple things that you're trying to get done. The brain has what we call executive function, and that means like the ability to plan things, to make decisions, to organize tasks, and to problem solve. There's also language, of course, right? How do we communicate with other people, either through speech or reading or writing? And then there's also visual spatial aspects of thinking, meaning how do we process and integrate visual information? How do we perceive things in space? So there's a lot of different types of thinking. And again, I think a lot of people will often just kind of lump all these things together and say, my memory's off. But all these different kind of domains can be affected. All right, so how common are cognitive problems in people with epilepsy? So there's, papers that people have written. And in general, people think that, up to 60 to 70% of people with epilepsy might have some form of cognitive impairments, okay? And this can range from pretty mild to pretty severe. But it's a large number of people that are affected, right? And people with epilepsy often rank cognitive impairments as one of the biggest problems associated with having epilepsy as well. That said, there's a fair amount of variability in both the type of cognitive problems as well as the severity of impairment that people with epilepsy might have. So let me give you some examples of that. So what we're looking at on this chart on the left here, we talked about different kinds of thinking, the different cognitive domains, and that's shown on the bottom here: language, executive function, memory, and so And each of these four lines here kind of represents different patterns of cognitive impairments that people have found in patients with epilepsy. And in this study, it was from patients specifically with temporal lobe epilepsy, okay? So we have the cognitive domains on the bottom here, and then sort of on the y-axis here, this indicates the level of impairment for someone. So if they have a score up high here, they're performing in the normal range. And then if their score is sort of further down here, that indicates more impairment, okay? So let's start with control. So people who don't have epilepsy are in this like grayish blue line. And you can see that across the board, across all of these cognitive domains, they're performing in the normal range, okay? And then there are people who have temporal lobe epilepsy who are what we call intact. They have also normal performance across the board, okay? And you can see on this pie chart here that at least in temporal lobe epilepsy, about 40% of people have normal cognition, all right? Now, there are people with temporal lobe epilepsy who obviously have other cognitive impairments. And so in this green line is what we're calling, sort of focal cognitive impairments. So what you see is that there's specific domains, usually in language, executive function, and memory, where people may not be performing as well as you might expect them to if they didn't have epilepsy. But then there's other domains, visuospatial motor, where they're actually performing reasonably well. And so that's what we call focal impairments, where there's only some domains are affected. And there on the pie chart here, you can see about 30% of people with temporal lobe epilepsy have these kinds of focal impairments. And then on the bottom here is in this orange line here, this is what we call generalized cognitive impairments, where in every single domain here, someone's not performing as well as they should be. And there, about 20% of people with temporal lobe epilepsy have these generalized kinds of cognitive impairments. So you can see there's different patterns, right? And based on different patterns, sometimes we can think about different causes for why people might have impairments in these areas. But the important point here is also that there's a significant number of people who have perfectly normal cognition as well. So while it affects a lot of people, it doesn't affect everybody. All right. So once we've identified that someone with epilepsy is having cognitive impairments, the next question is, what's causing these impairments, right? And sometimes the cause is pretty directly related to epilepsy, all right? So for example, it might be related to the underlying cause of someone's epilepsy. Let's say someone had a severe traumatic brain injury and then developed epilepsy after this. Well, that traumatic brain injury itself might be enough to cause cognitive impairments, right? So that would be related to the underlying cause of epilepsy. In some cases, in people who develop epilepsy at younger ages and kids who develop epilepsy, sometimes seizures and seizure medications can actually have effects on brain development, right? And so these effects of epilepsy could lead to cognitive impairments down the line as well. There's a direct impact of having frequent seizures on memory. Many of you know this, better than I do in terms of how your thinking is not quite as clear if you've had multiple seizures. So that, that can certainly cause cognitive impairments. And then similar to that, but not quite the same, there's something on, that we call epileptiform spiking on EEGs. So think of this as sort of brief blips in your brain waves, these little abnormalities in your brain's electrical activity. They last just a split second. But if they're occurring frequently, these electrical blips can actually interfere with your ability to think and remember things. And even if they occur during nighttime, while you're asleep, they can also affect your ability to remember things the next day. So that is something that can also cause cognitive impairments. Seizure medications, there are some seizure medications that are pretty well known to cause cognitive impairments. One of the most common ones is topiramate, or sometimes people refer to it as a Dopamax, because of the impairments it can cause. And then finally, if you've had a brain surgery to treat your epilepsy, sometimes brain surgeries can also result in some cognitive problems. So these are sort of all the epilepsy specific things that I think about when someone with epilepsy is coming to me and saying that they have problems with their thinking. But there's also things that aren't related to epilepsy necessarily, or not at least directly related to epilepsy. And so those things that I think about would be sleep disorders. Okay, so if someone has pretty bad insomnia, they're not getting, they're just getting a few hours of sleep a night. or if they have obstructive sleep apnea and the quality of their sleep over the night is not as good, then often their thinking during the day may not be as sharp. Okay. Same with mood disorders. If someone has really severe anxiety or really severe depression, often these can look like cognitive problems, or people can feel like they're having memory problems, when in fact what they have is untreated anxiety or untreated depression. Other mental disorders like ADHD can certainly cause cognitive problems, and you can see this more commonly often in people who have epilepsy. Substance use, alcohol, drugs can cause cognitive problems. And then there's neurodegenerative diseases like Alzheimer's disease. Certainly later in life, that's something that we might think about as potentially causing cognitive problems in people with epilepsy. And then I'll put their normal brain aging. We'll talk about this in a little bit, but there are some changes that happen that are normal changes to our brains as we age. But sometimes people can kind of recognize these changes and notice changes in their thinking when it's really just normal brain aging. But one of the things I want to say is, a lot of the patients who come to me, they're really worried about their cognitive problems because, they're like, oh, my memory's not good. Does this mean I have Alzheimer's disease? They may be in their 20s or 30s and like worried that they might have Alzheimer's disease. So what I'll say is that most of the cognitive impairments in people with epilepsy are not actually related to dementia or Alzheimer's disease. That's something we certainly think about as people get older. But people who are younger and middle-aged, most often those kinds of impairments are not related to dementia. All right. So if you think that you might be having some problems with your thinking or changes in your thinking, it's really important for you to talk with your neurologist. So how's that going to help things? So first, one of the reasons would be to better understand the kinds of, cognitive problems you might be having, right? And so, hey, what kinds of cognitive problems are present? What domains of your thinking are actually affected? How severe are the problems? What's causing or contributing to these problems? And in some cases, your neurologist might actually be able to provide reassurance that, you might feel like you're having a lot of memory problems or thinking problems. But, it may be that your performance on different kinds of tests show that you're actually doing okay, right? And so sometimes you can get reassurance from further evaluation. And then, of course, best case scenario is that, talking with your neurologist, they can help fix the problem or at least make things easier or better for you, right? And so this may be in the form of things like medication adjustments that can help your thinking, treatment of underlying conditions that may be contributing to some of your cognitive issues. Sometimes I'll refer people for cognitive therapy. Think of that kind of like physical therapy, but for the brain. It gives you kind of different strategies to work around some of the cognitive problems you might have. And then, setting up things like accommodations for school or work can really make a big difference in how you're able to perform in those settings. So talk to your neurologist. All right, so let's say you're coming to me and you're saying I have, cognitive concerns. So the first thing I would do is, have a clinic visit and have an appointment with someone and just try to understand what kinds of cognitive problems they're having and how it's affecting their day-to-day life. So, just things to think about if you want to talk with your neurologist about these problems. Things that can be helpful for this kind of appointment would be to bring either a family member or a friend who's around you a fair amount and who maybe has noticed some of these problems that you're having. Because sometimes having someone else who can kind of give their viewpoint in terms of like what they've noticed can be really helpful. The second thing would be to kind of come with a list of a few examples of like when and how often you've noticed certain problems, right? Is it that you've been forgetting conversations you've had just a few days ago? Or is it that you're getting lost while you're driving now? Or, maybe you've been performing pretty well at work or school, but then all of a sudden something's changed and, now all of a sudden you're not performing as well as you used to be. So these kinds of examples, these real world examples of how it's affected you can be really helpful for your neurologist to understand like the impact of these problems on you and what kinds of problems you're having. Um, and then, spend a little time thinking about, were there any changes that happened around the time when you started noticing some of these cognitive problems? And sometimes there may not be any, but, the things that I'll bring up are, maybe you had a change in medication or you added a new medication recently, and maybe it's been since that change that these problems started. That's a very helpful hint for your neurologist, right? Um, if you've had a change in your seizure frequency, maybe your seizures were pretty well controlled, but now all of a sudden you're having more seizures. That can be important, and that can certainly affect your thinking. Have you had any major life changes? Maybe a change in a job, right? And maybe your thinking hasn't changed, but the job is actually much harder than it used to be, or that you expected it to be, or changes in your living situation otherwise that can affect your thinking. Have you had increased stress? Is there more anxiety? Things like that. And then lifestyle changes, right? Maybe there's something so that you're not sleeping as well anymore. I don't know. You got a new neighbor who moved in and they're really loud at nighttime and you can't sleep anymore, right? These things are actually important. Or, substance use, right? Maybe you've started using marijuana or something like that, and that's a newer change. And that's when you started noticing some of these problems with your thinking. So it's important to kind of consider these things, be honest with yourself and be honest with your neurologist about what things may have changed. And that, can help them understand the big picture of what's going on and hopefully help you out. All right. So, there's a few different, medical tests we can do, or that'll often do, to try to evaluate someone's cognitive concerns. And, probably one of the more common ones to do is what we call a neuropsychological assessment. I'm sure probably at least a few of you here have had this done, and sometimes multiple times probably. But what this is it's usually these appointments are several hours. It's with a neuropsychologist, so someone who's specifically trained to kind of evaluate people's cognitive function. These appointments often take like half a day or so. They'll spend a lot of time talking with you about, your observations. They often like to talk with a family or friend about what they've noticed as well. And then you spend a lot of time doing like thinking tests. And again, these thinking tests will try to span all of those different cognitive domains that I mentioned earlier, right? Your memory, your language, your executive function, attention, things like that. And what you get out of that is much more detailed than your neurologist can do in a short appointment. But you get a really detailed profile in terms of like which cognitive domains do you have impairments in, or maybe that you're actually doing quite well in all of these domains. So that can be really helpful. And the other thing that can be helpful is, we talked about people who have different patterns of impairments in their cognition. And depending on like which cognitive domains are involved, you can sometimes that can help you think about what might actually be causing these problems in terms of, is it related to ongoing seizures? Could it be related to medications? Is it related to mood? Things like that. Our neuropsychologists are quite good, and they're very perceptive about these things, and they can often help us neurologists kind of figure out what's going on from that standpoint. So that's what something that I refer people to quite a bit is a neuropsychological assessment. The other nice thing about the neuropsychological assessment, it's kind of a snapshot in time, right? So you can, maybe you feel like your thinking's not great. You can get one of these assessments and get that snapshot in time. And then maybe a few years later, if you feel like things have gotten worse, or we can repeat that testing and kind of have a comparison to that baseline before. So that's nice as well. All right, so neuropsych assessment. And then the other studies that I'll think about, I'll often do an EEG study. And the point of the EEG study is often to see kind of how active someone's EEG is. Sometimes people can have seizures that they're not aware of, but can definitely affect their thinking. Or we talked about these epileptiform spikes, these electrical blips that can happen in your brainwaves. And sometimes, most people aren't aware when they're having these kinds of little blips. As I said, they only last a split second, but over time they can actually impact your thinking. And so often with the EEG study, I'm looking to see, how often your brain might be having these kinds of blips. And if it's pretty frequent, then that makes me think that, that's something that we could potentially try to treat with medication, try to reduce, and you might notice some cognitive improvements from that. I have ambulatory EEG Basically, what that is like an EEG study that you can wear at home for a few days. And I often like to capture a few days and a few nights of sleep. That way you can kind of get a sense of what the day-to-day variability is and kind of capture a fair amount so you have a sense of what's going on. All right, so that's what EEGs are for. Brain MRIs, I don't always get brain MRIs if someone has new thinking problems, but if it's been a while since you've had a brain MRI, then that's certainly something reasonable to consider just to make sure, there's nothing there like a tumor or other things that could potentially be, causing some cognitive changes. So you're looking for changes in brain structure that could cause cognitive impairments. And then last, a sleep study is another thing that I'll often think about. And another word for sleep study is polysomnogram, or PSG for short. This is a little different from an overnight EEG. So it often does involve EEG electrodes that you have on your scalp, but it also looks at things like your breathing patterns and your muscle activity during sleep. Because, as I said, there are some sleep disorders that, if you're not sleeping well, can definitely contribute to cognitive problems. I mentioned obstructive sleep apnea earlier in the talk, and that's something that's actually fairly common in people with epilepsy. People with epilepsy are at increased risk of having obstructive sleep apnea. And basically what that means is that when you're sleeping, your airways kind of like collapse on themselves and obstruct your breathing. So like, your brain, all of a sudden your oxygen levels go into your brain, decrease, and then your brain kind of wakes itself up and, causes you to wake up and, take a gasp, take a deep breath to get to oxygenate basically. But this can happen like hundreds of times a night in someone who has, poorly controlled sleep apnea. And so they may not realize it, but it's actually waking them up many times over the night. And so their quality of sleep might not be very good. And obstructive sleep apnea is something we definitely have treatments for, something that can definitely help improve your thinking during the day. So that's something I'll often consider as well. All right. So those are the testing. That's kind of my approach to, how I think about cognitive problems in someone with epilepsy and what kinds of tests to do. So let's talk about things that, treatments that can actually improve cognitive function now. And so for a lot of things, it's, if we find an underlying cause or something that's contributing to cognitive problems, we want to treat those things, right? So this could be adjusting seizure medications, either increasing them if we think that, you're having frequent seizures or frequent spiking activity during sleep that could be contributing, or, if we think that, maybe you're over medicated and kind of reducing your medication levels might actually help your thinking, that could also be another consideration, or simplifying your medication regimen. Treating things like anxiety, depression, as I said, can often have pretty impressive cognitive benefits. Treating sleep disorders, as we talked about, and then treating other medical problems, so there's, example of medical problems that can lead to poor cognitive function. One that I see a lot in older folks is something like an overactive bladder, right? So someone who is, goes to bed and then has to wake up a few times in the middle of the night to pee, right? And so that's basically like multiple times that they're getting up in the middle of the night, disrupting their sleep. So you're not getting good sleep quality, and that can definitely affect your thinking overnight. And so if you have medications, or you see a urologist and can kind of treat that, at least you are getting better quality sleep, and that can sometimes, help your thinking during the day. All right, so what else? Other helpful approaches to that don't necessarily address the cognitive function issue, but cognitive therapy. I talked about this a little bit earlier. And as I said, think of this like physical therapy or occupational therapy, but for the brain. And so if you're having problems with memory, then often they might work with you to develop strategies that can help you get through your day more easily. Might be things like keeping an appointment book, or keeping notes in a notebook, or having a calendar that like lays everything out for you easily so that you don't have to remember all of these appointments. That helps you organize a little bit better. So I do definitely refer patients for cognitive therapy, and many people find it helpful. medications that can possibly improve attention or increase alertness as well. If you have ADHD, treating that or helping you stay awake more during the day, so that you're more alert, can be helpful. And then, as I mentioned earlier, accommodations for work and school. This is something where it's really helpful to have the neuropsych testing, because then you have like objective, like these are the areas this person's having problems with, and often the neuropsychologist can kind of help you come up with, what kinds of accommodations you could get. Meaning, kind of, let me give you an example for like accommodations for school. Sometimes people may have, reduced processing speed. And so giving someone a longer period of time to take a test, right? Maybe they get an extra hour, 2 hours to be able to take this test. And now they don't have to be worried about this processing speed issue. They can take their time and show that they actually learned the material, right? So something like that. And so again, it doesn't necessarily help your thinking, but it helps set you up for success in whatever environment, gives you an environment that's more conducive to either learning or getting your work done successfully, right? All right. So I think we're moving on to the next section of the talk. So those are like how I think about cognitive problems in people with epilepsy and how you go about evaluating and treating them. So let's move on to the next section, which is on epilepsy, brain aging, and dementia. And so here, really the question is, how do we live our best lives as we grow older with epilepsy? So first, let's just talk about normal brain aging. This is something that happens in everyone as we grow older. So as we grow older, our brains undergo normal structural changes. Okay, so here I'm showing you a plot of total brain volume, basically like brain size, okay, over time as people get older, right? And the lines here show you kind of the average for men in blue and then women in red. But you can see that as people get older, we lose brain volume. This could be because we're losing some brain cells, we're losing some of the connections between our brain cells, some of our brain cells will shrink over time. All those things contribute to decreasing brain volume over time, okay? And related to some of these structural changes, we also see some changes in our cognitive abilities as we grow older. So this could be, people have slower processing speed as they get older. They have reduced working memory, so they're sort of less able to hold as many things in their mind at one time compared to how they used to do in the past. They might have reduced what we call autobiographical memory, meaning, recollection of events that happened to you, over your life. You may have more trouble remembering some of those details. Sometimes people have a little bit more difficulty with problem solving. Maybe your thinking's not as flexible as it used to be able to solve problems. So all of these things can happen as people get older. But I think the important thing to note is that normal brain aging doesn't impair someone's ability to perform their normal everyday activities. It may be something that people notice, okay, but it's never so severe that it should impair your daily function. Okay, so then let's talk about how normal brain aging is different from something like dementia. Okay, so as I said, normal brain aging, there is some decline in cognitive function as people get older. That's what we expect. But in some cases, people may have a cognitive decline that's greater than what we expect for their age. Okay, and then we start to worry about whether they might be developing early stages of dementia. So the precursor to dementia is something that we call mild cognitive impairment, okay? And so people with mild cognitive impairment, they've had a decline in their thinking. They're often aware of this, right? They can tell you, my memory is not as good as it used to be. And often maybe your family and friends have recognized also that your memory is not as good as it used to be, right? But despite that, you're still functioning overall well. You could still work, you could still take care of your finances, cook, do all the normal things that you do in your day-to-day life. Okay, so that's mild cognitive impairment, where there's some change in your thinking that's significant, but not enough to affect your day-to-day living. Now, when someone's cognitive impairments become severe enough, then they can start interfering with someone's day-to-day living, right? And when that happens, that's what we call dementia. So dementia is basically where you've had a decline in your thinking, and that decline is significant enough that it's starting to impair your daily activities. And that can range from, mild dementia up to severe dementia, depending on how impaired you are and how much help you need from day to day. Okay. And so with dementia, we're talking about someone who is no longer able to cook meals for themselves. They may no longer be able to pay their bills. They can't figure out how to pay their bills or write checks. Maybe they've done a job their whole life and had no problems with it, and all of a sudden now can't do that job anymore. It's not all of a sudden. These changes are typically very gradual changes over time. Okay, but at some point they're not able to do that job anymore. So these are kind of the stages that we think about when someone's kind of beyond this normal brain aging. And so what I want to point out is, the way I've defined mild cognitive impairment and the way I've defined dementia has to do with how your brain is functioning cognitively and how you're functioning in your day-to-day life, right? I've said nothing really about what causes these changes in function. So, dementia it's a symptom, really. It's not a disease. Dementia just means that your thinking has declined, severely enough that it's affecting your day-to-day living. But there are many diseases that can cause dementia. So Alzheimer's disease is one of the most common causes of dementia, right? And so many people will often interchange, Alzheimer's disease for dementia. But, there are other things that can cause dementia as well. I've listed a few of those here below. All right. So that's, how I think about the differences between normal brain aging and dementia. All right. So I want to talk next about a concept that's called cognitive reserve. Okay. So it turns out that what someone's brain looks like, for example, on an MRI scan, or even if, you're looking at someone's brain under a microscope at an autopsy, right? What someone's brain looks like doesn't always match up with how well that person's brain functions. For example, I might have an older adult who passed away, and at autopsy, we look under the microscope and we can see severe abnormalities in their brain. The kinds of abnormalities you might see in someone who has like end stages of Alzheimer's disease, okay? But then you find out that actually this person, right up until they passed away, was functioning pretty normally, right? They were living independently, they were cooking their own meals, and they didn't have any really obvious signs of memory problems, right? So how do we explain this mismatch between like what someone's brain pathology looks like and, and how they're actually functioning from day to day, especially if they have a lot of brain pathology and they're still functioning quite well from day to day? Well, one of the ways that we explain this is through this concept called cognitive reserve, okay? So think about cognitive reserve as your brain's ability to function well, even in the setting of brain disease or injury. Okay, so think about it as like it's how your brain is able to compensate for diseases. It's how your brain is able to find other ways of getting things done, other ways of thinking about things, if the usual way of getting things done suddenly becomes unavailable. All right. So I think about cognitive reserve in terms of like brain networks, how different parts of the brain communicate with each other and work together. All right. So high cognitive reserve means that you've developed brain networks that are efficient and that are flexible. So I want to give you kind of a very simple example of how to think about this. Okay. So it's so simple, it can be drawn with Crayola crayons here. So say you live in this town, okay, and you want to go from your house, over here to the pool over here, right? And it's a pretty simple way to get there, right? You just take this road over here, okay? So what happens now if you have some sort of injury, okay? And now all of a sudden the path that you were going to take to go from your house to the pool isn't available anymore, okay? Well, if you had developed other roads, okay, other brain networks, right? Even though this one road was damaged, you might still be able to get from your house to the pool using other networks or other roads, right, to get around that problem. And so you've used these other networks to compensate for the fact that, this main road is no longer working. And that's kind of what cognitive reserve allows you to do, okay? It might take a little longer to get from your house to the pool, right? These paths are a bit longer than the initial one you took, but you could still get there, right? So, one of the best things about this concept of cognitive reserve is that it's closely related to your life experiences and your lifestyle, okay? And that means that it's something that we can modify and continue to improve over the course of our lives. So we know that things like education, having a lot of intellectually or socially stimulating activity, these are things that build cognitive reserve over time, all right? And having these kinds of factors can actually reduce your risk for developing dementia. So that's why cognitive reserve is a really important concept to kind of think about. So how does it actually reduce your risk for dementia? Okay, so let's imagine someone has early stages of Alzheimer's disease, let's say. And Alzheimer's disease, it's a slowly progressive disease. Your cognitive function gradually worsens over, a period of years, right? And so I'm showing this cognitive decline in this black curve here. So when this person's, cognitive function declines past a certain point, that it starts to interfere with their daily activities, okay, like let's say this is that point here, then that person has developed dementia, okay? Now, what would this curve look like if this person had, let's say, had a severe head injury a few years ago? So if they had a severe head injury, there's been some damage to their brain networks, and now other brain networks are having to compensate for this injury. And this person's going to be starting out with a lower cognitive reserve, right? So even with the same amount of, Alzheimer's disease pathology going on in their brain, they're going to be on a different trajectory shown by this red curve here, right? And so with less cognitive reserve, what you actually see is that this person's going to develop dementia at an earlier age than they would have otherwise, right? But let's take the opposite example now. And so let's say that someone has a high cognitive reserve, and here you see the curve actually shifts the opposite direction, right? So even with the same amount of Alzheimer's disease pathology here, if you're starting out with higher cognitive reserve, you'll actually develop dementia at a later age, okay? Depending on how much later this age is, it's possible you might actually pass away from something totally different without ever developing dementia, right? And it's kind of a weird way to put it, I know, because none of these outcomes sounds good necessarily, but I mean, I think a lot of us would be pretty happy if we were able to like live our lives and never develop dementia, right? So the bottom line is that brain injuries, low cognitive reserve can put people at increased risk of developing dementia earlier in life, whereas having higher cognitive reserve can in some cases delay the onset of dementia, right? And some people, it might delay that onset to such an extent that, for all practical purposes, it's prevented this person from developing dementia, okay? All right, so now that, you understand differences between normal brain aging and dementia and the concept of cognitive reserve, let's now think about how this applies to people with epilepsy. So I'm going to start with the bad news. Okay, and the bad news is that people with epilepsy are at increased risk of developing dementia. Most people agree it's about a 2 to 3-fold increased risk compared to someone who doesn't have epilepsy. All right, but that said, there's a large amount of interperson variability in terms of what risk you might have for developing dementia. When did you first develop epilepsy? What caused your epilepsy? How frequently do you have seizures, or maybe your seizures are well controlled? How many seizure medications you take? There's all these things that kind of play into that, to the final result of whether someone else might develop dementia or not. But what I want to consider actually is kind of 3 different groups of people with epilepsy, and based on when they first developed epilepsy, and whether it's in childhood, okay, midlife, or as an older adult. And let's talk about kind of how I think about the risks of developing dementia for people in each of these groups, because it kind of changes based on age. So let's start with epilepsy that started when someone was very young. Okay, so the unique feature here in this group in terms of cognitive function is that their epilepsy coincides with a period of time where their brain is still developing, right? So their seizures can actually affect how their brain developed. So this is, I'm not, you don't really need to look at this closely, but this is a schematic of different stages in normal brain development. And the main point here is that there's a lot of stuff going on, but essentially normal brain development is happening from very early age up until almost your late teenage years. Okay. And so having epilepsy during this time, being exposed to seizure medications during this time can have, adverse effects on brain development. So let me show you an example of that. All right. So this is a graph from a study that was done where they looked at learning and memory performance in about 1,000 patients who had temporal lobe epilepsy, okay, and as well as about 1,000 patients who didn't have temporal lobe epilepsy. And they looked across, different ages across the lifespan. And so the blue curve shows you what verbal learning looks like, at different ages. Okay, this is kind of the normal curve. All right. And what you see is that, your verbal learning performance actually improves over time. It actually peaks around age, 18 or so, around age 24 or so, okay? And then after that, it starts to decline a little, which is a little scary to think about, but that's what our brains normally do, okay? So what happens in people with temporal lobe epilepsy? This is the green curve here. So there's two things that I want to point out. So first, they have a lower peak in their memory performance compared to someone who didn't have epilepsy, okay? So they don't reach as high performance as someone who didn't have epilepsy. And then second, they actually start, they also peak earlier than someone without epilepsy. And so they start that decline in their learning and memory at an earlier age as well, okay? So putting this into the concept of cognitive reserve, this person may have reduced, you may have reduced cognitive reserve as a result of developing epilepsy at an earlier age, where it affected your brain's development, okay? So that's epilepsy in early life, okay? And so really the important things here are knowing that, those people who have epilepsy in early life, they're at risk of having reduced cognitive reserve. So it's really important in early life to try to maximize, intellectual stimulation and learning in school and putting accommodations in place to make sure that these kids are able to learn to the best of their abilities at young ages. All right. So what about epilepsy that happens in early to mid-adulthood? And here, we're largely past the age where epilepsy and seizure medications would affect brain development, but this is still early enough in life that this group is going to be chronically exposed to a number of different risk factors for dementia. And I'm also going to include people who developed epilepsy earlier in life too, because these kinds of chronic exposures also affect them as well. So what kinds of risk factors are we talking about? Here's a list here in terms of repeated seizures, exposure to seizure medications, reduced physical activity, reduced social interactions, sleep disorders, mood disorders. These things can all kind of add up over time. And what I'll say is that these things can either reduce cognitive reserve, if you're having recurrent seizures or exposed to seizure medications, or again, if you're not interacting a lot with other people, if you're not getting out exercising, things like that, these can all affect your cognitive reserve. And they can also increase your vascular risk, meaning how like heart healthy you are, basically. And we'll talk about this later because this is actually really important for people with epilepsy. So, I realize that bringing these things up, it might sound kind of like doom and gloom to you, and really that's not my goal here. I want to make sure that you're aware of these issues and these risks, as someone who has epilepsy. But at the end of the day, it's actually things like cognitive reserve and vascular risk factors that we actually have some control over and can change, right? We can do things in our lives and make certain decisions in our lives to improve those things. And so if you get anything out of this talk, really it's that thing that, you're at risk for, developing these kinds of cognitive disorders over time, but anything that you can do to improve your heart health and your brain health can really be important for mitigating some of that risk. Okay. And then last, let's talk about epilepsy in older adults. So this is, people who develop epilepsy at later ages. The most common causes of epilepsy in older adults are actually stroke, traumatic brain injury, as well as neurodegenerative disease. It turns out that, in almost up to half of the people who have late onset epilepsy, there's no obvious cause for epilepsy. But we sometimes think about epilepsy that develops in older adults as kind of a warning sign, okay? because people who develop epilepsy at later ages, we know, even though they have no obvious cause for their epilepsy, they actually have an increased risk of developing a stroke in the future, as well as increased risk of developing dementia as well. So as I said, some people, this is still an area we're learning a lot about and have a lot to learn about still. But there's some people who wonder whether, developing seizures later in life might be some warning sign that there's something going on in the brain that we need to kind of address or work to prevent. As I said, this is an area of active research. Okay. So that's, how I think about epilepsy, brain aging, and risk for dementia. And in this last part of the talk, I want to focus on like, what can we do about this, right? How do we optimize our brain health? How do we optimize brain health in someone who has epilepsy? All right, so it turns out that modifiable risk factors account for up to 40% of all dementia. Okay, that means that there's things that you can change that will actually reduce your risk for developing dementia. And this is a schematic that basically summarizes, all the available evidence on risk factors for dementia over the lifespan, from early life, going on to midlife, and then into later life. All right. And you can look at some of these things, less education. That's something, or less education in early life is a risk factor for dementia. That's something that, as a society, we can change, right? In midlife, things like hearing loss, hearing aids are available, right? So that's something that we can change. Traumatic brain injury, there's ways that we can reduce people's risk of traumatic brain injuries in terms of wearing helmets, seat belts, things like that. High blood pressure, alcohol, obesity. Again, these are all things that there are either medical treatments for or lifestyle changes that you can do to kind of reduce your risk for these things. So I think of this as kind of like a nice roadmap for, what things can we do to actually improve the situation. This is not specific to people with epilepsy. This is kind of a general for the general population, but these things are things that we can all, benefit from. All right. I've talked a little bit about vascular health before, but I think this is like a really important slide. And this is talking about the importance of vascular health as it relates to people specifically with epilepsy. So this is data from a study that was just published last year. And they looked at data from a study called the UK Biobank. This is a study from the UK. It's a large population-based study. So they had over 500,000 people, okay, between the ages of like late 30s to early 70s. And here they looked at people specifically in the study who had focal epilepsy and who did not have dementia at baseline. Okay. And of those, 500,000 people in this study, there are almost 4,000 people in the study who met those criteria, having focal epilepsy and no dementia at baseline. And so these, the people who participated in these studies, they had regular physical exams, they had blood tests, they had cognitive tests over time. And in the study, they followed people for an average of about 12 years to kind of see who would go on to develop dementia and what kind of factors increased risk for dementia, okay? And so this table shows, some of the major findings here of how cardiovascular risk actually affects the risk for dementia in people with epilepsy. So the control group is shown in gray here. So we're comparing to someone who doesn't have epilepsy and who has low cardiovascular risk, okay? And we're just setting that to 1 as the control, and everything else is going to be in comparison to this number 1 here. So if you have focal epilepsy and you have low cardiovascular risk, your risk for dementia, at least in this study, was a bit higher than what I've said. It was fivefold, 5 times, someone else who doesn't have epilepsy. But look what happens as your cardiovascular risk goes up. So if you go from low risk to moderate risk, now your relative risk for dementia goes from 5 to 8. And if you go from moderate to high, that's almost a 14-fold increased risk, right? Or almost three times the risk of if you had low cardiovascular risk. So this issue, and we're still learning a lot about it, about how the health of your blood vessels that feed your brain impacts your risk for dementia down the line, but this is a really hot area of research. In epilepsy, it does seem to have this really interesting effect where it seems to be especially important in people with epilepsy. So again, this is kind of your call to arms in terms of, make sure your blood pressure is controlled, make sure You know, if you have diabetes, that's well controlled, things like that. We want to maximize your cardiovascular health. So just in terms of what went into this cardiovascular risk, so you can see, this is kind of how they calculated the risk score. So the things that went into this risk were whether you had high blood pressure, high cholesterol, diabetes, obesity, kind of measured by a waist to hip ratio, whether you were a smoker. And so here, 20 pack years. The way you calculate pack years, if you've smoked, is, you know, how many packs a day did you use to smoke and how many years did you do that? And you multiply those two things. So 20 pack years could be someone who smoked a pack a day for 20 years. Okay. So if you smoked for that amount of time, you know, you get an extra point for that. Here they also included a genetic test result, ApoE. This is a test result that affects someone's risk for dementia, but also their cardiovascular risk. But these are kinds of the things that, you know, we potentially have control over, right, in terms of how we live our lives and getting regular medical checkups to make sure these things are well controlled. And you can see sort of how they derived whether someone was at low risk, so having none of these risk factors, versus moderate risk, having 1 to 2, versus high risk, having 3 or more of these things. Okay. All right. And then the other kind of point I want to touch on that's pretty relevant to people with epilepsy is traumatic brain injury and the risk for dementia there. So, you know, many people with epilepsy have higher rates of traumatic brain injury, especially if you've had convulsive seizures, right? You might fall, hit your head pretty hard during some of these seizures. So how do TBIs affect risk for dementia? Now, the data I'm going to show you here is not specific to people with epilepsy, but I think it's still informative, okay? So this is data that came from a large population-based study in Denmark, followed almost 3 million people aged 50 or older. And they got information about like which people had traumatic brain injuries and how many based on like emergency room visits, hospital admissions, things like that. And they used other national registries that they have in Denmark to kind of determine if and when people developed dementia down the line, okay? And so they adjusted for things like, you know, medical history and other kinds of comorbidities. But what they found was that, you know, the more TBIs someone has, the higher their risk of developing dementia down the line, okay? So if you have just, you know, 1 traumatic brain injury, your risk is a little higher, you know, 1.2 compared to 1. But, you know, 5 or more TBIs, you know, you're accruing more risk there, you know, 2.8. So, you know, of course, we're trying to minimize seizures and in that way minimize the risk of, you know, hitting your head, you know, during a seizure. But, you know, that said, it's also important to be proactive about minimizing the risk for these kinds of injuries and other activities in your life. Again, wearing helmets if you're biking, wearing seatbelts if you're in a car, things like that. Anything you can do to kind of reduce the kinds of head injuries you might have, or even thinking about sports, right? And maybe trying to avoid some sports where head injuries are more common. All right. Okay, so this is kind of a summary slide. You know, I've talked about a number of different things that we can do to protect our thinking over the lifespan. And this is a table that kind of summarizes the recommendations from, you know, 6 major health organizations on you know, what they think, you know, people should do to reduce their risk for dementia based on, you know, available evidence as well as expert opinion. And so you can see the things, you know, here, and, you know, many of these recommendations have to do with vascular health, as we talked about, right? Getting exercise, eating a good diet, making sure your blood pressure is controlled, things like that. And what I'll point out is that a lot of these other things I think are really important for people with epilepsy. So, you know, these are things that tend to be a little more challenging for people with epilepsy, right? In terms of engaging socially. You know, having epilepsy definitely makes it harder to get out and to be with people sometimes. Getting adequate sleep, you know, managing stress and depression. Depression is something that is really common in people with epilepsy, right? It kind of goes along with epilepsy in many patients. So, you know, again, these are things that I think you should know about, right? You should just understand that they can affect your risk. But think about that many of these things are things that we can treat, right? Either medically or with lifestyle things. And it's not that, you know, you have to go out and change everything you're doing in terms of your lifestyle. You know, I think about making these kinds of lifestyle changes as like putting a little bit of money into a savings account, every month. It's not that you have to go gung-ho and be crazy, but, even a little bit goes a long way if you're doing it consistently over time, right? And so just being aware of these things so that you can make choices over time. Many of you have many years ahead of you to live. So being aware so that you can make the appropriate choices, I think, is really important and can help you in the long run. Okay, and this is just another way of summarizing this. So to maintain brain health, you want to think about things that increase your cognitive reserve. So trying to keep your mind active, getting as much education as you can, taking classes and things you might be interested in, reading books, learning new things, right? Protect your brain from injuries, get enough sleep, and stay socially engaged. And then, the other big category that hopefully I've driven this point home well enough tonight is controlling vascular risk factors. So making sure you're seeing your primary care doctor regularly, getting your blood pressure checked, getting, your blood sugar and cholesterol checked to make sure that if there are problems there, you're working with your primary care doctor to optimize and to, make sure those things are treated. Staying physically active, that's a hard one, I know, for many people with epilepsy. But to the extent that you can, or finding ways to be able to stay physically active is worth thinking about. Having a heart healthy diet. If you smoke, public service announcement, please quit smoking. That's like one of the best things you can do for your health, is to quit smoking. And then avoid excessive alcohol consumption. And again, a lot of this, I hope it doesn't sound daunting, and really, I think a little can go a long way. So just being aware of it and making choices, as you go along that kind of are in line with these recommendations. You don't have to do anything crazy and, start a new diet all of a sudden today and try to keep that up for the next 50 years. But, next time you're making choices about what should I eat, have some of these things in mind. Okay, so we're at the last slide here. We're just at the hour here. Oops. So cognitive problems are common in people with epilepsy. We talked about the kinds of problems that people might have and their causes can differ for different people. And most problems in people with epilepsy are not related to dementia, at least during most people's lives. You talk with your neurologist if you have problems, if you have concerns about your thinking. We talked about the bad news, of course, which is that epilepsy is associated with increased risk of dementia as people grow older. But again, the good news, which is that we have some control over this, and we can definitely change things in our life to reduce our risk. So we talked about all these different things in terms of staying mentally and physically active and controlling our vascular risk factors. And doing this, again, over many years can drastically reduce your risk. So with that, I will stop. I'm sorry, I haven't been looking at the chat at all. So if there's questions, we can try to get to those. But I'm happy to take any questions if you have them at this point. I'm not sure how we're doing this, if people are gonna call on somebody else or what, but.
Thank you, Dr. Lamb. We do have some questions in the chat. The first one that got sent to us was, do you have any tips on what to do in the meantime if you're waiting for a neuropsychiatric evaluation? Because the waits for children are running for about 2 years.
Yeah, they're not quite as bad for adults, but for adults, it's about 6 to 9 months, something like that. So that's definitely tricky. Again, the neuropsychiatric evaluation, it's nice because it provides a baseline and it can get at some of the different issues that might be causing a child's, cognitive issues. But even before that, you might be able to talk with your neurologist and see if you can get some accommodations in place at school. Some people might be willing to do that. And then, of course, trying to evaluate for other things and working with your neurologist to maybe adjust medications if you think there are medication issues that might be causing things, or even doing some of the tests that we talked about, right? Like EEGs, brain MRIs, things like that, just to try to get at other aspects of someone's health that might be affecting their thinking.
See, Tansy has her hand up.
Yes. Thank you. And you'll see my question later on, so just erase it.
Okay.
Because it's a very obvious repeat of, I developed epilepsy in freshman year of college, and I've had 2 left temporal lobectomies. one in 2020 and one in 2025. The first one removed, this is a great deal according to my family, because I don't remember. It changed my personality. They're like, you are a different human. It's like we lost our daughter. They love
Oh,
this
wow.
person too, but you know, and it removed a great deal of educational skill of what I developed over with my degree. When the second one occurred, I was going, something is wrong, guys, something wrong, something is wrong. And the second left temporal lobectomy, because I was the 30, 40, 50 seizures a month. We had no option.
Wow. Okay.
Yeah, it was like that or become like a piece of toast. So the second one, it removed the vast majority of my life from that point back. Like, I don't remember giving birth to my son. I don't remember. I've never thought about this until it was repeated repetitively. So thank you. Does that count? Do those count as a brain injury? What was the 3 words, the term for it? Brain, you mentioned it.
Like traumatic brain injury?
Yes, a
Okay.
TBI. Does
Yeah.
that, or is that a totally different connection? And I'm finished talking, so thank you.
No, no worries. Yeah, that's a great question. So usually when I think about a traumatic brain injury, we're kind of thinking about a head injury where someone gets hit in the head, right? Or something like a gunshot wound to the head, something like that. But you're right to think that like an epilepsy surgery is kind of a traumatic brain injury in some way, right? Like, taking out part of the brain. So I don't know that I wouldn't think that the numbers that I showed you necessarily reflect the same way. And obviously the kinds of cognitive problems that you've had resulting from the surgery are a lot more severe than just someone getting hit in the head. They have more to do with really just that part of your brain that got removed that was obviously doing important, still having some important function in terms of your memory. But I would say that without that temporal lobe, and now that you're without that temporal lobe, your cognitive reserve is down, right? Because you don't have those kind of brain networks there that are doing what they used to do, and so you're having to use other parts of your brain to try to compensate for that. Does that make sense?
Yes, it does. And thank you very much, because we were talking about doing a third lobectomy. And I'm like, I'm a little bit scared because the last one I had to have a year of speech therapy, which ended up
Wow.
good results.
Yeah,
So, okay, well, thank you very much.
you're welcome.
Yeah.
Someone else asked, are there any brain games to help with memory?
Brain games to help with memory. That's a pretty common one that comes up because there's a lot of brain games that are kind of advertised to people, aren't there? Like you've probably heard of like Lumosity, and there's probably other ones that have come out since then. So the way I think about brain games to help with memory is I wouldn't, how do I put it? In a way, they are, they're something that provides some stimulation, right? Some stimulation to your thinking. They make you have to think hard and try to figure things out. If you don't enjoy them, I wouldn't force yourself to do them. I would try to find other things that are more interesting to you that could kind of still keep your mind, your brain stimulated and active and learning, but in doing something that's more enjoyable to you. I don't think that there's a lot of evidence that the brain games necessarily help. You can see that like people can do better over time if they play them more over time, but how that actually translates to day-to-day living, I think is not quite as clear.
Shelby,
Someone else. Oh, sorry.
ahead.
No, go.
Shelby, you can go ahead and read the next one.
Someone else asked if the drug Prevagen helps adults with epilepsy with cognitive defects and memory issues.
Okay, I think you said Prevagen, is that right? I didn't.
Yes, sorry, I've never heard of it, so I missed
No,
it.
no worries, no worries. So Prevagen is it's not actually a medication or a drug. It's actually marketed as a nutritional supplement, okay, or a dietary supplement. So it's kind of along the lines of a vitamin, or kind of a cocktail of vitamins. It's been marketed towards people trying to prevent Alzheimer's disease, actually. what I'll say about these kinds of nutritional supplements is that, the kind of data that people need to have to show that the supplement actually is helpful is it's kind of non-existent, really. It's treated very differently than like a medical drug, right? Like, for example, let's say you take a drug for epilepsy, right? Like a prescribed medication. That medication had to go through a lot of approval. They had to show that the medication works to treat seizures and reduce seizures, right? And they had to show a lot of evidence for that to be able to be a prescribed drug. When you have dietary supplements, that kind of regulation doesn't actually exist in the dietary supplement world, right? So they could say these things without having to actually prove that it works. So I don't actually recommend those kinds of dietary supplements for any of my patients, really. I think that there's not enough evidence to show that A, they work, and B, I hate to say it, but it's kind of a predatory industry in some ways, how I think about it, because there's just so many people as we get older. A lot of people are worried about, I don't want to get dementia, right? I don't want to get Alzheimer's disease. And so these companies kind of prey on people's fears from that standpoint and say, well, if you take this, you can prevent that. But there's really no evidence that that's actually true. So I generally don't really recommend any kinds of like dietary supplements. At least right now, I don't think there's any that show obvious benefits to preventing dementia.
Now the question is, can repeated head strikes over many years or drop seizures cause a sudden change in memory and abilities, like not knowing the day, month, or the year?
So that's an interesting question. What I would say is I would be very surprised if they would cause a sudden change. Okay. Again, if we're thinking about something that happens over time, then you might notice a gradual change from that standpoint, but I would be concerned if there was a sudden change, meaning that, I don't think that, those repeated head strikes are likely to account for that sudden change. And I would think that you would want to get other kinds, bring this to your doctor's attention, because maybe there's something else that's actually changed more suddenly to cause those changes in your thinking. Does that make sense?
Does. Shelby?
Another question is, let me find it again. Are there patterns of cognitive decline in patients with Lennox-Gastaut syndrome?
Okay, so that's a more complicated question, and I think it's a little tricky because there's kind of a range of people with Lennox-Gastaut syndrome. For those of you who've never heard of Lennox-Gastaut syndrome, it's what we call an epileptic encephalopathy. It tends to happen in young kids, and it can be associated with really hard to treat seizures, as well as developmental delays. And I'll be honest, I'm not an expert in Lennox-Gastaut syndrome, especially in kids. So I don't know if there are specific patterns of decline. What I can say is that I know a lot of people with Lennox-Gastaut syndrome have pretty significant impairments in terms of their neurological development. I have a few patients with Lennox-Gastaut syndrome, and what I'll say is that many of them as adults are pretty dependent for their care. But again, it's not something that I see a lot of in my clinic to be able to comment on.
Mm-hmm. Here's another one. When is it time for a guardian or healthcare proxy for someone with epilepsy, and who makes that decision? What is that process?
So that's a good question. It's I think it's hard for me to answer that one without knowing kind of specifics, and I think there's many cases where the specifics matter, right? So what I would say is, if that's something that you're thinking about, I think it's worthwhile to bring that up to your neurologist as well as to your primary care physician, and kind of ask their thoughts about whether they think it might be an appropriate time for something like that.
Shelby?
Can people with epilepsy and intellectual disabilities such as Lennox-Gastaut syndrome benefit from cognitive testing?
I think so, yes, but I think it really depends on what kind of intellectual disabilities and the severity of the intellectual disabilities, because to do cognitive tests, you have to be able to kind of participate in the tests, and they do definitely make cognitive tests for people who have, intellectual disabilities. But again, it really depends on how well someone's able to participate in those in a meaningful way. Worth asking your neurologist for sure, though.
Mhm. I think this is a follow-up to that question. Can a neurologist prescribe or order cognitive therapy to improve cognitive reserve in those with intellectual disabilities and epilepsy?
Yeah, I often will order cognitive therapy for patients of mine. And again, I think it depends on the things to think about are kind of what are your goals for doing this, and again, in someone with intellectual disabilities, again, that can span quite a range, right, in terms of how well someone's able to participate in the cognitive therapy or not. So that's something to talk with your neurologist about. See if they think that whoever you're thinking about is whether they'd be able to participate in something like this.
There was a discussion in the chat from some parents who were talking about how it sounds like medications might be doing more damage than good when it comes to memory, which causes some terrifying feelings. And then another parent had shared that sometimes they said it's like a double-edged sword and picking the option that's not so much worse.
Yeah.
Do you have opinions on this or more elaboration on it?
Yeah. Not just for kids, for adults too. It's always it's such a balancing act in terms of, we know that if seizures are uncontrolled, then that can affect thinking. And I see in the chat someone also mentioned SUDEP. So, that can have risks in terms of thinking. But, at the same time, if you're over medicated, that can also affect someone's thinking. So this is something that, you really have to work with your neurologist. And if you are worried that your kid is over medicated, that's worth bringing up and asking, whether there's something they can do. Maybe it might be trying to simplify a medication regimen, or trying to reduce doses and seeing if, you might be able to get away with a lower dose and still have reasonable seizure control. But it's such a case by case basis. But it's something that I, even as a neurologist, I struggle with adults too, right? In terms of people feeling like medications might make them feel mentally foggy. But, is treating their seizures better than being mentally foggy? Again, that's something that we kind of have to deal with on a case by case basis.
Mhm. It looks like Lauren was asking a question of another person. I think it's Erin. Are you trying to locate a neuropsychologist in private practice or at a hospital? And someone said, I'm sorry, I'm not sure. Also, I meant I had my neuropsych test. And because of the results, my doctor referred me to Obscotch to get resources to help me develop skills to improve my memory. So,
Oh, okay. I think, yeah, let's see. It looks like there was a conversation that someone was having, or that multiple people were having.
yeah.
So, the issue with neuropsychologists and wait times is, something that we're struggling with, at least in the Boston area. I don't know what it's like in other areas, but, I have had patients trying to go to other places or other private practices to see if they can get their testing done sooner. It's worth thinking about. It's a trade-off, though, again, I'm probably biased, but again, I tend to refer to our neuropsychologists at MGH, and there I know that people are kind of equipped to evaluate cognitive problems, specifically in people with epilepsy. We have specific neuropsychologists who I refer my patients to, where I trust their evaluations, right? And so, because I'm not as familiar with, other neuropsychologists at other places. It's not to say that they also wouldn't do a great job. I'm just not as familiar with some of them. So that's why I tend to refer internally. But again, depending on, what you need from the neuropsychologist, if that's what's waiting, that's what's, you're waiting on to get accommodations for your kid or something like that, then, definitely worth trying to see if there are people who have sooner availability. Someone mentioned hopscotch here. I didn't really have time to talk about that, but that's a program that I know at least a few of you here have tried out. It's kind of a self-management kind of program that's run through Dartmouth, but I think there's people in the Epilepsy Foundation who can also kind of help you get set up with that if that's something that you're interested in. It's meant to help people who have epilepsy and who have kind of cognitive impairments related to that, and at least help people learn to manage those cognitive issues and learn to kind of live their best lives, in spite of some of those cognitive problems. So if that's something that that you might be interested in, talk to, I don't know, Shelby, who should we refer people to? Talk to your friendly FNE community health worker, and they can probably figure out how to get you involved with that program.
There are a few more questions if you have time for it, Dr. Lamb.
Sure.
So one of the questions was, I don't know which slide it was for when they sent it, but they asked if a study included lipoprotein A. I think it was for the slide before you were talking about traumatic brain injury near the end of your presentation.
Okay. I don't know the answer to that offhand. I have to go back to the paper. I'm seeing if I can try to find it, or if someone wants to unmute and ask, that'd be fine too.
I can ask a different one that's still here.
Mhm.
Someone was wondering, how at risk is the midlife group for dementia?
So I would say in general, even in the midlife range, down the line, we're talking not like someone who's going to imminently develop dementia, but we're talking about down the line as they grow older. I think people are still finding about 2 to 3-fold increased risk. Okay. Again, many, personal variables that influence that risk for a given individual, but kind of as a population, 2 to 3-fold increase. Again, this is an area where people are really, starting to do a lot more research than in the past. And so, our hope is that we'll start to understand a little bit more, how that's affected by different epilepsy factors, right? In terms of like how severe your epilepsy is, what kind of epilepsy you have, things like that. And so, again, when you just say someone in midlife who has epilepsy, that can mean a lot of different things, right? From someone who, takes seizure medications, but in general has pretty well controlled seizures, versus someone who has, pretty severe epilepsy on multiple medications and still having a lot of seizures. So there's just so much variability in there. It's hard to give a specific answer, but across the population, and recognizing that's a broad population, 2 to 3-fold increased risk.
Similar to that, someone was also wondering, where does the 16-year-old fall in those age groupings and with regards to dementia, I believe.
Yeah, the 16-year-old, they would fall, at least in that schematic I showed, it kind of early life, but really kind of later in life, right? Because most of the brain development has happened by 16. There's still some, finishing touches, but I would. They're right at that kind of intersection between early life and sort of midlife.
Mm. There's one here that I think it's Erin. She said, "Thank you so much. Our oldest is 5, and this is his first year in school. And we're seeing some struggles with memory processing. It's heartbreaking. He has only had 5 episodes, seizures in his lifetime, but each one was 20 to 40 minutes long. And these are still so many, I'm sorry, there are still so many unanswered questions on what caused them and if any damage may have been caused."
Yeah, well, I'm sorry to hear that.
Yeah.
But I think it's, the good things are that, you're recognizing these fairly early.
Mhm.
And I think that it's important to talk with his neurologist or talk with his pediatrician about some of these concerns. If he's struggling in school, this is a really good time to get accommodations in place and an IEP, to help kind of tailor things so that he's able to learn as well as he can. And then, you know, talking with his neurologist about whether or not, you know, is there any signs of what happens to his brain during these seizures, and are there other things that, you know, would be important to be taking into account to kind of help him function as well as he can be.
Mm.
You know, still an important age to be able to intervene and still make a significant improvement. So I'm glad you recognized it early.
Shelby, it looks like that's it.
Yeah, I was doing one last scan. I think we covered everything.
All right, you guys are experts now. I have nothing left to offer you. Um, well, I hope, again, I hope that did not come across as like a doom and gloom thing, but really just something to be mindful of, and to, you know, so that you can change things and hopefully live long, healthy, brain healthy lives. But it's really been a pleasure talking with you guys tonight. Hope
Yes,
everyone has a good night.
you.
Thank you, Dr. Lamb. Thank you.
You're welcome.
Bye-bye.
Bye now.
Bye, everyone.